Acquired hemolytic anemia. Pathophysiology. Premature intravascular destruction of red cells is referred to as hemolysis. The mechanisms of acquired hemolytic anemia are divided into immune-mediated destruction and mechanical destruction, Table 12. All forms of intravascular hemolysis lead to the formation of spherocytes and a reticulocytosis. Following destruction of the red cells, hemoglobin, Hb, binds to haptoglobin. The serum haptoglobin transports the Hb to the liver where the iron is stored as ferritin. The globin chains are broken down to their constituent amino acids and the protoporphyrin ring is metabolized to bilirubin. The serum haptoglobin level falls as it is used up and Hb then circulates unbound. The Hb may be excreted in the urine, turning the urine dark, black water fever of falciparum malaria. Hb may be taken up in the tubular cells of the kidney, where it forms hemosiderin which can be detected in urinary casts. Unconjugated bilirubin rises and patients may be clinically jaundiced. The non-immune hemolytic anemias also cause red cell fragmentation. Spherocytes, polychromasia, and fragmentation can be seen on the blood film. Autoimmune hemolytic anemia. Autoimmune hemolysis occurs because the red cells become coated with autoantibody, complement, C3d, or both. The coating of the red cells leads to premature lysis within the circulation. The direct antiglobulin, DAG, test, also known as the Coombs test, is positive. Autoimmune hemolytic anemia is subdivided into warm and cold types depending on whether the antibody binds antigen most avidly at a warm temperature, 37 degrees Celsius, or a cold temperature, 4 degrees Celsius. Warm hemolytic anemia. Warm hemolytic anemia may occur secondary to autoimmune disease or lymphoproliferative disorders or may be idiopathic. The DAG test is positive to IgG, C3d or both. Prednisolone 1 mg/kg daily is the first-line treatment. Red cell transfusion is indicated in severe symptomatic cases. If steroids fail, consider immunosuppression, e.g. azathioprine, intravenous IgG, cyclosporin, a monoclonal antibody, rituximab, directed against the B cells responsible for production of the warm antibody, and splenectomy. Cold hemolytic anemia. Cold hemolytic anemia, cold hemagglutinin disease, is a condition principally of the elderly. The responsible antibody is IgM, which binds to the red cells as the blood cools in the peripheral circulation. As well as causing complement-dependent lysis, the pentameric IgM agglutinates red cells causing the hands and feet to turn blue in cold conditions, acrocyanosis. Hemolysis and agglutination can occur at different temperatures and one may be more clinically problematic than the other. The condition is often idiopathic but may occur secondary to mycoplasma infection, infectious mononucleosis, or lymphoproliferative disorders. Treatment is supportive. Keep the patient warm and transfuse using a blood warmer if necessary. Exclude an underlying treatable cause. Steroids are of no proven benefit. Resistant cases may respond to alkylator therapy such as low-dose cyclophosphamide. Hemolytic transfusion reactions. The majority of blood group system, ABO, incompatibilities result from errors of identification at the bedside, when sampling or setting up a transfusion. Laboratory errors also occur. Patients experience an immediate feeling of dread when they develop hemolysis. This is due to the development of shock and associated chest and back pain. The transfusion should be discontinued immediately and the bag sent back to the laboratory. The laboratory and the consultant in charge need to know urgently about the matter. Blood for a Coombs test and further antibody analysis is required, plus biochemistry and clotting profiles. Blood cultures are required in case there is an infective element. Active resuscitation with fluids is necessary. Adrenaline, epinephrine, may be required intramuscularly. A brisk diuresis and close monitoring of central venous pressure is essential. There is a 10% mortality rate from hemolytic transfusion reactions. Drug-induced hemolysis. Many drugs can cause hemolysis by a variety of mechanisms, Fig 19. Penicillin can attach to the red cell membrane producing an antigen that stimulates antibody production and lysis, Hapton mechanism. Methyldopa leads to antibody production. The antibodies cross-react with red cell membrane antigens and stimulate hemolysis, autoimmune mechanism. Quinine forms an immune complex with an IgM antibody. The complex then binds to the red cell and complement-mediated lysis occurs, immune complex or innocent bystander mechanism. The appropriate treatment is to stop the drug, keep the patient well hydrated and support the HB if necessary with red cell transfusion. Steroids are of no proven value. The condition usually remits after stopping the drug. Dapsone and sulfasalazine cause hemolysis by direct oxidative stress. Patients with glucose 6-phosphate dehydrogenase, G6PD, deficiency are particularly vulnerable, but all patients on these drugs should have regular counts checked. As with oxidative hemolysis in G6PD deficiency, Heinz bodies may be seen on the blood film and HB may turn the urine dark. Microangiopathic hemolytic anemia. The hemolysis in microangiopathic hemolytic anemias occurs because of the shredding of red cells as they flow through intravascular fibrin strands. This is often associated with a coagulopathy and organ damage due to microthrombi, and management is directed at resuscitation, supporting the cardiovascular system and the failing organ, and treating the underlying cause and correcting the coagulopathy. There is a significant mortality associated with these conditions.